Right, thank you very much, Aryan, for the kind introduction, and I'd like to thank the organizers of this wonderful multidisciplinary symposium for inviting me all the way from Singapore. This is my first visit to Leiden, and I'm very pleased to be here, especially since we now have quite a strong connection with Leiden. Dr. Mark Bergmans, the previous speaker, was working with us in Singapore for 2 years, and he came back last year when we organized a regional conference in interventional radiology. And then, of course, the person hiding behind the sign is my colleague, Dr. Sean Chan. Spent almost a year here in Leiden and has just gone back a few months ago. So, as was previously shared by Aryan, that actually the precursor for interventional radiology was actually angiography, when X-rays were first developed as a diagnostic tool, and then they later became an imaging modality for intervention. And the development of cross-sectional imaging, ultrasound, CT, MRI, actually came much, much later than angiography. So as we move forwards into more complex procedures, you've heard over the course of the day, there is a need now for better, accurate targeting, and I think the answer is that we now need hybrid imaging for our more complex procedures. You've heard from Mark how ultrasound is very important for needle guidance, and it's excellent for solid and fluid field structures, where cross-sectional imaging is in terms of targeting. Where we work now, we're using as many of these modalities for complex procedures. You can see in this picture that we have the ultrasound machine. We have a flat panel angiographic unit that's capable for Conebeam CT. But in the background in that room, you can see a CT gantry in the same room as we have all the other equipment. So I'm mainly focusing on the use of hybrid angiography CT systems, or the use of cross-sectional imaging during angiographic interventional procedures in my talk. A lot of that experience actually has been developed in Japan. The first available unit in Japan was developed in 1992, where they actually had a CT scanner in the same room as an angiography unit, but you really had to move the patient to get into the gantry. Later on, they developed the concept of having the CT scanner on rails so that the patient didn't have to move on the table at all. This is the concept of the use of a hybrid CT and angiography unit. You can see that the gantry is on rails, so there's no need to transfer the patient from the angiography mode to the CT mode. Now, I'm glad to share with all of you our experience in Singapore General Hospital, where we installed a unit in 2008. Basically, this system has a 16-slice multi-detector CT with CT fluoroscopy capability. The angiography unit is a flat panel 40 cm by 30 cm flat panel system with Conebeam CT and rotational angiography capability, and we have a separate ultrasound unit in the room as well. So this is what the unit looks like. The 16-slice CT on rails, and the patient, the procedure table, and the flat panel unit. And you can see the ultrasound in the background. I'm focusing my talk mainly on techniques during vascular procedures, typically angiography. And there are two ways that we could use it. One is to have the convenience of the equipment in the same room. So in case the patient needs pre-procedure CT or CT angiography, you can have the pre-procedure diagnostic scan done and then followed by the intervention immediately. The other is to have the CT incorporated in between as an imaging protocol during the intervention to guide selective or super selective vascular intervention, and then also to assess the results as you treat the patient. And for the purposes of my talk, I'm going to focus on the second utilization. So here's an example of a patient who has previous partial right lobectomy for hepatocellular carcinoma. This is the diagnostic CT, and you can see the areas of multifocal tumor recurrence. She was referred to us for transhepatic chemoembolization, and we did it the usual conventional way, only under digital subtraction angiography. You can see the tumors lighting up on angiography, and we went ahead and performed the chemoembolization procedure. This is post-chemoembolization. Unfortunately, 5 weeks after the procedure, when we performed the diagnostic CT, you can see that there is evidence of some recurrence. This is the showing the lipidol uptake, but there is a tumor that we did not manage to treat, and there's washout and enhancement there. It's shown there. So the patient was referred back for a follow-up chemoembolization, and this time we performed this in the CT angiographic suite. We first performed a CT arterial portography with a catheter in the superior mesenteric artery on the principle that tumors will not show up if you only enhance through the portal veins, and they will show up as filling defects. And then we follow that up with the catheter right within the hepatic artery, and as we inject the contrast into the hepatic artery, we acquire CT images, and you can see the enhancement of the lesion in this picture during CT hepatic angiography. Lower down, inferiorly, you can see the images and the area of tumor lighting up. And we then followed up with, now that we know where the tumor is and that the catheter is in the right place, we followed it up with chemoembolization. And this is the post-procedure digital subtraction angiography, but we have the assurance of also doing a plain CT immediately to show where the lipidol uptake is, and you can see that we clearly have treated it with a good uptake of lipidol in that area, and similarly, where this other tumor was, it is well treated by lipidol. Marco has spoken to you about Conebeam CT, which is capable of also producing cross-sectional images in the angio suite, and I will not dwell on the history or the principles of how it developed. As he has mentioned, with the flat panel detector technology, it's improved the cross-sectional reconstruction of the images with higher resolution and less decrease in contrast. However, the reconstruction time has, while it has decreased from an initial development from 5 minutes to now 16 seconds, it is still a significant time for inpatient interventionists in the room. So, as is shown, we have the benefit of working with both modalities in our center. That's the hybrid CT room. This is one of interventional units that is capable of performing Conebeam CT. This is the workstation taking 16 seconds to reconstruct the images, and I won't dwell on the cross-sectional imaging images that can be achieved. Just to show you the range of Hounsfield units or tissue that it can image, 3D rotational angio, of course, could only cover bone or contrast-enhanced structures. CT would show you the whole gamut of structures as shown here, and Conebeam CT is somewhere in between. Basically, it's able to image soft tissue of 10 mm lesions with at least 10 Hounsfield units contrast difference. How do we use it in our vascular interventions? Here's an example, very similar to how we use it with the CT scan room, and you can show that the quality of images is actually quite good. This is a diagnostic multi-detector CT of a hepatocellular carcinoma. This is with intra-arterial injection during Conebeam CT, and you can see the same lesions quite nicely. Here's an example of a female patient with multifocal HCC referred for chemoembolization, multifocal lesions within the left lobe as shown. When we performed the left hepatic angiogram, we were not very happy with some of these vessels. Clearly it doesn't look like within the liver, and we wanted to be very sure. So we performed Conebeam CT, and that showed us clearly that we were also enhancing the stomach from left gastric branches. So we proceeded to advance the microcatheter further distally into the left hepatic artery, repeated the Conebeam CT, showing that there's no more enhancement of the stomach, and that gave us confidence to proceed with the chemoembolization procedure. Here's another patient, multifocal HCC treated before. However, it was pointed out by our diagnostic colleague that there may be a lesion there. Very difficult to tell. So what we did was we brought the patient for angiography with a view for treatment, and this is the CT arterial portography that shows a filling defect in the arterial portography. So very clearly there has to be a lesion there. So we hunted it down. This is the hepatic angiogram. We can't find the lesion being supplied by the usual hepatic artery vasculature, even with CT. So we hunted for other vessels, and this is the right renal angiogram, and you can see that the right inferior phrenic artery is supplied from the right renal artery. And we went in selectively, and then, took the opportunity to perform. This is CT and not Conebeam CT, catheter-directed injection, and this gives us the assurance that that lesion is now lighted up from the lower branch of the inferior phrenic artery, and we then proceeded to treat this patient, which otherwise I think on angiography alone we would not be able to detect. And here is post-chemoembolization lipidol uptake of that lesion. We are also using this technique quite a bit in selective internal radiation therapy with yttrium-90. The whole idea of this technique is to deliver a high radiation dose to a liver tumor and reduce as minimum as possible to the normal liver, and not to deliver any to the extrahepatic organs. This is just an example of the types of products that are out there. Just suffice to say that typically we are talking about 20 to 60 microns with a beta energy of this range. And if you compare selective radiation therapy with chemoembolization, we are actually talking about very different techniques and very different sizes of particles that we deliver. Chemoembolization is in this range, Y90 is in this range. All right, and here's an example of what can be done. Tumor within the right lobe, very vascular tumor. Here's the angiography, treated 3 months, 6 months, 12 months, basically a complete response on quite a big tumor. The procedure involves a few steps for those of you who are not familiar. It requires a workup procedure where we assess the vascular anatomy, and we actually inject technetium MAA into the hepatic artery to look for lung shunt and tumor to normal liver ratio for dosimetry. Then 1 to 3 weeks later, we then bring the patient back. We may, at that point of time, occlude extra hepatic vessels that are in danger of being infused with the radiation, and then administer the Y90 microspheres into the selected hepatic artery. So it is very important that in SIRT that careful planning is performed, because it is critical to treatment success and prevention of complications. We work on this in close collaboration between our diagnostic radiologists and the nuclear medicine physicians. And in our experience, the hybrid angio-CT system is a very valuable tool in performing this procedure. Here's another example, a huge tumor in the right lobe supplied by 2 arteries. And when we perform the diagnostic angiogram, we also acquire the CT as shown here. And then these pictures are then later used by our nuclear medicine physicians to assess the degree of the amount of dosimetry to deliver to the tumor. This is important because the arena that we work in, there is a lot of variation in the vascular anatomy. Many of the patients that we treat have either prior surgical resection or chemoembolization, so the vascular anatomy can also be altered. And we all know very much about the extent of extrahepatic supply of HCC. So meticulous angiography technique is very important. Here's another example. Left hepatic angiogram performed. Sorry. And similar to an earlier case that I showed you, supply to the stomach, and it's really not a good thing to deliver the Y90 into the stomach, because you will get radiation necrosis ulcers. So with our experience using intra-arterial CT angiography, we find that we can get superior depiction of the vascular anatomy, both from the tumor supply, the nature of the anatomy, and also from also information on aberrant extrahepatic collaterals. This information allows us safe delivery of the Y90 microspheres. These are some of the planning norms that we are trying to target here. We're trying to get about 120 grays into the tumor. We're trying to limit the radiation dose to non-tumorous liver to 50 to 70 grays, and the radiation dose to lungs to less than 30 grays. Here's an example of 2 patients after planning. This has a lung shunting of 20%, so this patient qualifies for Y90 treatment. This patient has a lung shunting of more than 70%, would not be suitable for Y90 treatment. In terms of calculation of doses, there have been many different methods described. Initially, a lot of it was empirical. In our group, we've now used the combination of imaging that we acquire in the workup for these patients, and with this information, we are able to deliver personalized predictive dosimetry through our techniques. A little word about prophylactic cord embolization. As mentioned, in many other groups, a lot of them have routinely embolized the gastroduodenal artery and any other suspicious bowel collaterals that they see on angiography. In some studies, up to almost 90% of patients have prophylactic cord embolization. With this technique, visualizing on the CT acquired images the supply, we have actually in our series minimized embolization to less than 1/4 of the patients. Here's an example of that I showed earlier, where there was supply to the left gastric artery, and we've embolized it before delivering the Y90. Mark has also done a study looking at visualization of the hepatic falciform artery, which is actually very, very difficult to visualize on diagnostic angiography. He did a retrospective review and found that we could detect more than slightly over 50% of the falciform arteries in this group of patients that he looked at. He compared that with the other techniques and showed that digital subtraction angiography could only detect about 12%, and technetium MAA SPECT CT only about 14% of these arteries. And here's an example. This is the falciform artery, as you can see there. On intra-arterial CT, you can actually trace that, and it's opacified very nicely, as shown here. And in this case, you know, we went in and did super selective embolization of this artery before we delivered the Y90. What about applications beyond the hepatic territory? Very quickly cover that. Here's a 83-year-old female patient who presented us with bleeding per rectum, and on the diagnostic CT angiography, you can see that there is extravasation of contrast into the bowel. However, when the patient came down for angiography, in an old patient is not able to hold her breath well. Those of you who are involved in this technique know sometimes it's very difficult to detect where the bleeding point is, and you can see on this superior mesenteric digital subtraction angiography that it's really tough to know where the bleeding point is. So we have the benefit of immediately performing CT with the catheter in the superior mesenteric artery, and here it is. That's where the extravasation is, and this gives us the confidence to go in to look for that artery, super selectively catheterize it, and you can see the extravasation, and we went ahead and performed embolization. This is another patient who presented to us with massive hemoptysis, and we have in our patient population patients with chronic pulmonary tuberculosis and scarring, and here's the CT showing the amount of scarring in the lungs. And when we performed the bronchial angiogram, what we were not very happy about is this vessel here, right? And we know that the spinal artery can have collaterals coming from the bronchial arteries. Now, to be very sure, we performed the CT as we injected into the bronchial artery, and here you can see enhancement of the spinal artery, reconstruction showing that spinal artery. So this gave us the indication that we had to go distal to that branch to perform the embolization, and we managed to perform the embolization of the bronchial arteries and the collaterals safely without any complication. Here's another patient, similar, presenting with massive hemoptysis. Again, the angiogram showed a tiny branch moving towards the vertebra again. This time, we performed Conebeam CT, and again, this confidently shows us that the vessel that we saw is not a spinal artery, and that we could go ahead and perform the embolization safely. Some reconstruction pictures on Conebeam CT, and this is post-embolization. Just very briefly to share with you, we've also done some radiation dose estimates for Conebeam CT in our work. In fact, in this study, we compared two Conebeam CT systems with that of the MDCT, because we're interested to know what kind of doses we would expose our patients to. We performed this using a phantom, and by placing multiple TLVs in the rondo phantom. And these were our findings. In fact, we found that the dose levels for Conebeam CT and MBCT were quite comparable for the head protocols, but in the abdomen, actually the dose levels were higher on Conebeam CT. And one could imagine that because the collimation for Conebeam CT are not as close as for MDCT. We also found interestingly a significant difference in the eye doses between the two Conebeam CT systems. And this is something that we need to know as end users, that this can be dependent on the different arc of rotation that different systems employ during Conebeam CT. So, take-home points for my talk is that cross-sectional imaging during angiography and vascular interventional techniques improves treatment efficacy through accurate targeting, dose proportioning, dosimetry and delivery, enhances patient safety with reduced non-target embolization treatment, and improves the operator confidence for decision-making in complex procedures. I'd like to acknowledge the work of the whole team in the Interventional Radiology Center at Singapore General Hospital for the work that I shared with you today. Thank you very much.